First of all, taking the blessings from Almighty, it's my pleasure to welcome everyone to this webinar. We have participants joining across India and abroad. I would like to wish all of you and your families all the very best for your health, safety in this difficult time of COVID-19 outbreak. Stay safe and take care. On behalf of Department of Zoology, Nirmala College, I gladly extend a warm welcome to all of you who choose to spend your valuable time here today with us. Hope this webinar gives you some amazing insights. Before we start, let me explain you some of the important points. While listening, you can type your doubts through chat box. Kindly mute your audio and video. The link for response will be sent to your WhatsApp and email in the question answer session itself. Fill it and your certificates will be reaching in your email. Now, let me introduce and welcome the resource person of today's webinar, Mr. Anil Peter. He was a faculty at University of Auckland, New Zealand, specialized in diagnostic and interventional cardiology. At present, he is a faculty at St. George Hospital, Sydney, Australia, specialized in advanced life support and cardiology. Thank you, Anil sir, for spending your valuable time with all of us. It's a matter of pride that you're an alumnus of Nirmala College. I wholeheartedly welcome you, sir, to this international seminar.
Thanks, Annie.
Now, I am handing over the mic to the resource person for delivering the lecture on Love Your Heart and Celebrate Life. Thank you. And once again, I welcome you all. Thank you.
Okay, so thanks, Annie, just to introduce me to this particular program. Well, in fact, it's the first time I'm actually doing a webinar on a Google Meet. Hope everything will work well. So I believe everyone in India, it's a morning time for you. So good morning to everyone in India. Actually, I'm speaking to you from Australia, from Sydney. In fact, I live in a place called Wollongong. It's about 100 kilometers south of Sydney. It's one of the most beautiful areas in Australia. And I'm really privileged to talk to you today on heart health. It kind of gives me a nostalgic feeling when I talk to the staff and students of Nirmala College, where I actually spent the first couple of years of my university education. I was also a classmate of Miss Annie from my, at those days it was pre-degree, it was called. Currently it is called year 11 and year 12. So basically I was a classmate of Annie in year 11 and year 12, the same Nirmala College, Muvattupuzha. Okay, anyway, let's go to the topic, love your heart and celebrate life. So, in fact, I like to talk if you like to listen. But if you do not follow my accent or do not understand any medical words that I say, please interrupt me and get it clarified. Also, please let me know to keep it short if I'm talking too much or going in too much depth. And maybe you can give me a heads up in that case. Now, heart represents love. Many youngsters, as you know, love others' heart. Now, my message here is to love your own heart, because your heart loves you so much. The heart is one of the first organs to form in our body. It in fact started beating since you were about 3 weeks old in your mother's womb. Since then, it has been beating continuously without taking any rest even for a minute. It beats around 100,000, that is 1 lakh in Indian language, times every day. You know what would happen if your heart takes rest even for a minute? So everyone, love your heart in return, look after it. Now today let us see how to look after a heart and what will happen if you don't look after a heart. So we can talk about several heart conditions, but we don't have time to hear all of that. Now, as I understand, there are students, teachers, medical and non-medical people among you who are my listeners today. So I'm not quite sure at what level I should pitch the lecture today. I'll start at the basic level and can go to any advanced level if you are keen to listen. So today we look at two dangerous conditions, which are heart attack and cardiac arrest. As I told you, there are a lot of other heart conditions which we should know about, but we don't have time to discuss everything. But we will discuss a few conditions under these two titles, that is heart attack and cardiac arrest. And the reason why I took these two topics, that is heart attack and cardiac arrest, is many a time when someone dies suddenly, we think they had a heart attack. And many hospitals in India, unfortunately, try to convince the relatives that the patient had a heart attack, as the people won't question anything. So particularly, I actually remember my mother-in-law was admitted in a famous hospital in Ernakulam, Kochi, for an operation for a brain tumor. But she received the worst care post-operatively that led to severe electrolyte imbalance resulting in a cardiac arrest. But the hospital told us that she had a heart attack. It's a very easy and unquestionable answer. So anyway, let's look at both these scenarios in detail. Let me try to bring up a PowerPoint presentation in front of you. In fact, I do not really like to present on PowerPoint, but on a webinar, PowerPoint I think is must. Otherwise, you'll be always constantly seeing my face. And I don't have a whiteboard to show you things, do not have a projector to show things. So I think I need to use a PowerPoint here. So let me try to bring up a PowerPoint in front of you. So maybe I'll go in hiding, but from now you'll be able to see the PowerPoint. Please let me know if you can't see it. Okay, so love your heart, that's our title today. So as we said, first we'll discuss about the heart attack. So heart attack is a common term, but the actual medical term is myocardial infarction. I believe all of you heard this particular term, myocardial infarction or MI. And what is myocardial infarction? So myocardial infarction. So basically the infarction, which means the cell death or tissue death of the myocardium. And the reason is basically decreased blood supply to the myocardial tissue, usually due to an occlusion of the coronary arteries. They are the arteries supplying the heart. So that's the definition basically, infarction of the myocardium due to ischemia or decreased blood supply to the myocardium. Now what are the types? Again, there are different terminologies used across the world nowadays, but the common terminologies that we use are STEMI and non-STEMI. So mainly there are two types of heart attacks or myocardial infarction, which are STEMI and non-STEMI. STEMI means ST elevated myocardial infarction, and non-STEMI means non-ST elevated myocardial infarction. And ST elevation is a classic finding in the ECG of a patient who has got a heart attack. So if an ST elevation can be seen in the ECG, then that particular heart attack we call STEMI. And if the ST elevation is not seen, instead maybe an ST depression or a TA inversion, then we'll call it a non-STEMI. Now the basic difference in terms of actually what's happening in the heart is in a STEMI, which is a major heart attack, which is also called a full thickness heart attack. The earlier terminology was transmural myocardial infarction. And the other one, non-STEMI, which is a little bit more minor heart attack, only a small portion of the myocardium involved, not the full thickness, which we used to call subendocardial myocardial infarction. Hope this is clear to you now. So basically STEMI is a big full-blown massive heart attack. Non-STEMI is a little bit of minor heart attack. And it's important we should know the difference between MI and angina. Angina just simply means pain. To say it's a chest pain, we have to actually say angina pectoris. Pectoris means chest. So MI versus angina, obviously angina is it's not a heart attack, but obviously there's a bit of ischemia, a bit of decreased blood supply to the myocardium, causing a chest pain. That is angina pectoris. And that can be either angina pectoris, which is a stable angina or an unstable angina. Stable angina means obviously you've got a stable pattern for the angina. You know when it's going to come. If you're doing some exercise or something like that, it will come. If you take a bit of rest, then obviously it will go away. That's a stable pattern of angina, which is called stable angina. And now unstable angina is unexpectedly when you, you used to be able to climb a few flights of stairs. You used to be able to walk a kilometer. It was absolutely fine. But on one fine day, when you were walking the same kilometer of distance, you start to get the chest pain. Or on one particular day, in the morning, when you're climbing the same steps, now you're getting a bit of chest pain. That is unstable angina. It has actually gone out of the normal usual pattern of angina. So that is the difference between MI and angina. Obviously in MI, that's not the case. There will be a sudden severe ischemia to the heart muscle, leading to the death of the heart muscle. Now, what are the causes of myocardial infarction? So, as everyone knows, dyslipidemia or increased lipids, cholesterol in the blood is the commonest cause of angina. Sorry, commonest cause of heart attack or angina, either way. Now, what happens? How can there be an increased cholesterol or fat in the blood? So, commonly we can say lifestyle is a big issue. So, what do you mean by lifestyle? Too much fatty carbohydrate food, or lack of exercise, smoking, lack of sleep, etc. Let's go through this a little bit more in detail. Obviously, you know, I don't have to really explain about in terms of what kind of food, like, you know, too much fat in the food, too much carbohydrate in the food. They're always dangerous, as you know. Everyone knows this in this world. Now, a little bit about lack of exercise. What do you mean by lack of exercise? So, nowadays, life is very sedentary. You know, we always travel in the car. People don't like to walk. People don't like to actually, you know, walk even for a short distance. So that kind of a lack of exercise, a sedentary lifestyle, that's obviously a causative factor for increased cholesterol in the body, accumulating cholesterol in the body. We are not really burning our fat away. And I'll talk to you a little bit more about exercise when I tell you about the prevention of heart attacks. Now, in terms of smoking, as you know, everyone knows, I think, so smoking actually can lead to heart attack or ischemic heart disease. Now, lack of sleep. There are a lot of studies about this lack of sleep. People actually didn't care much about this lack of sleep. They did exercise. They had a very healthy lifestyle. They were very careful about what they eat and what they did not eat, everything. But studies have recently shown that lack of sleep also can be a direct cause of heart attack. So there have been many studies. I'm just trying to tell you one of the findings of one of the studies that I recently read. So those who are sleeping 6 hours or less had about 1.7 times the death rate of those sleeping 7 or 8 hours per night. And too much sleep was also not good. So those sleeping 10 hours or more had about 1.8 times the mortality of those who reported to sleep 7 to 8 hours of sleep. So ideally, the sleep requirement is about 7 to 8 hours. If you sleep 6 hours, about 1.7 times the death rate. If you sleep 10 hours or more, about 1.8 times. So almost double, basically. So another thing is diabetes. So again, everyone has heard diabetes is a direct cause of heart attacks. Now, what happens in diabetes? So diabetes, the people with diabetes, you know, their blood will be highly dyslipidemic. So it's actually a prime risk factor for coronary artery disease. It can also affect the heart muscle, causing heart failure. And actually speaking, the link between diabetes and heart attack is multifactorial. There are a lot of other reasons also how diabetes actually can cause heart attack. We don't have time to go through all of that today. Now, other thing is family history. So family history is a very important factor in heart attack. Sometimes, you know, people actually, they look after themselves, they exercise enough. But if they've got a family history, it's a strong reason for heart attack. We actually say, if you have a family history in your family of a heart attack, then there's the probability for you to get a heart attack is almost double. So even here, when we do the blood test and things like that, if you do have a family history, the doctors will start treating you. Even if your cholesterol level is a little bit lower than lower compared to other people who do not have family history. So that's a very important factor, but we can't do much about it. Only thing what we can do is we can fix the things what we can fix. We cannot really change our family history. Now the other thing is ethnicity. So in terms of ethnicity, there are a lot of ethnic variations, a lot of races in this world who are more prone to heart attack. But we don't really have to learn about all of them. Let's learn about ourselves. So Indians, particularly South Asian. South Asia means not only India. So India, Pakistan, Bangladesh, Nepal, Bhutan, Sri Lanka, Maldives, they all South Asia. So South Asians also got a very high probability for heart attack. In fact, they say it's about 2 to 4 times actually. At least we can say double chance for heart attack. So in Australia, if we all have blood tests and everything or blood tests or all of the other kind of screening tests, if you are an Indian, they'll definitely start treating you, even if your cholesterol level is a little bit lower than other people, other whites here. So it's that important, family history, ethnicity, all those kind of things. So these are the common causes of heart attack. Now, even if you do not have any cholesterol in your body, even if you don't have any dyslipidemia, increased cholesterol in the blood, there can be another reason, which is a little bit rare reason that can cause a heart attack. This is actually called SCAD. The explanation is spontaneous coronary artery dissection. I don't know whether you have heard of this. Many of you must have heard of this. This is not that common, but it is there. Recently, just a couple of days ago, we had a patient like that. So majority of the patients are females, but males also can have. So the other day we saw a patient, actually this person was a male. Now, associated with pregnancy, associated with a lot of physical exercise, stress, all those kind of things, this can actually happen. So what is spontaneous coronary artery dissection? So coronary artery dissection. So basically the coronary artery's wall inside actually will dissect, will split, will break. And that actually will expose the subendothelial tissue to bloodstream and there's a clot formation. So that's exactly what's happening in spontaneous coronary artery dissection. You don't need to have any dyslipidemia in this case. So that obviously occlude the blood supply suddenly will cause a heart attack. Now a little bit about the causes of angina. So angina also obviously doesn't lead to cell death. It doesn't lead to an infarction of the myocardium. So it is not an MI, but it could be kind of a warning sign for an impending heart attack. So angina, obviously the definite cause of angina is definitely atherosclerosis again. That is the deposition of fat in the coronary arteries. That is called atherosclerosis. So that itself is the cause of angina. But angina can also be caused by many other factors. One of the things is called coronary artery spasm. So you don't need to have a dyslipidemia. You don't need to have any fat deposition in the coronary arteries. Your coronary arteries actually can go into spasm temporarily. Just it will narrow itself. That actually can decrease the blood supply to the heart, cause angina. Another thing probably you've heard of this, apical ballooning syndrome or Takotsubo cardiomyopathy, or sometimes you must have heard of this as broken heart syndrome. So apical ballooning syndrome, basically the apex of the left ventricle will kind of balloon out. So that particular phenomenon is actually called apical ballooning syndrome or Takotsubo cardiomyopathy. Takotsubo is a Japanese term. It's actually, Takotsubo means octopus trap. They make some particular jars to trap octopus. So the apex of the left ventricle actually will take that shape. That is why it's called apical ballooning syndrome. That also will actually manifest as angina. When you do an angiogram, we can actually see this ballooning of the left ventricle, and that's how we diagnose it. Obviously, it doesn't usually cause a heart attack, but the diagnosis is important so that we can rule out everything else. Then a lot of other reasons also for angina pectoris. Hypertrophic cardiomyopathy is actually the left ventricles or the right ventricles, basically, mostly the left ventricle, the ventricular wall get thickened. So these are a few reasons actually for angina. There are other reasons too. Now, a little bit about the pathophysiology, what's exactly happening in the pathology of the heart attack. So as we mentioned, in a common man's language, obviously, heart attack causes because of deposition of fat in the arterial walls, coronary artery walls. So what exactly happens is this plaque will be this fat deposits will be there in the coronary arteries, which we call the plaque. Now the plaque over time can rupture due to many factors. Now when it ruptures, the subendothelial tissue, which is actually the tissue, the surface of it's a bit difficult to explain, but the endothelium is actually the lining of the coronary arteries. So the tissue underneath that will be exposed to the bloodstream if the plaque ruptures. So when there is exposure of the subendothelial tissue to bloodstream, there will be factors like the platelets in the blood will be adhering there. It's called platelet adhesion. So this platelet adhesion will actually causes formation of a clot or a thrombus. So that will actually occlude the blood supply completely, cutting off, basically completely occluding the coronary arteries, cutting off the blood supply to the myocardium. And that actually will cause heart attack. Sudden cutting off the blood supply, that actually is causing this heart attack. So that's pathophysiology in short. Now what about the clinical features of heart attack? We all know chest pain. Chest pain is the commonest clinical feature of heart attack. But there don't have to be chest pain all the time. MI can happen in sleep, can also be precipitated by heavy hard work, mental stress, everything like that. Anyway, the commonest clinical feature is chest pain itself. Other clinical features are actually diaphoresis. Diaphoresis means profuse sweating, nausea, vomiting, all those kind of things. Kind of impending doom, anxiety. Obviously, we have heard about heart attack a lot. Heart attack is a killer disease. So if you get a chest pain, obviously, and if the chest pain is really massive, is really strong, obviously you will have that anxiety as well. Now, chest pain, when I say, it's the nature of the chest pain is very important. It's kind of a crushing, squeezing. Sometimes people will report, I feel like as if an elephant is sitting on my chest. So many types of chest pain really. Usually a pain that is caused by just heartburn or a bit of acidity is slightly different from the heart attack chest pain. This one is actually retrosternal, that is right under your sternum, your breastbone, and then it's kind of a squeezing, crushing kind of chest pain, and diaphoresis and all those other symptoms. Now, MI sometimes can come without any symptoms at all, which we call silent MI. So in silent MI, basically you don't need to have any kind of symptoms. In other words, you may have some symptoms, but very unrelated to the usual heart attack symptoms. So these symptoms can be like a jaw discomfort or something like a indigestion. Sometimes you can feel a bit of nausea, feeling weak, sometimes like that. And sometimes it can be just in sleep. You won't even feel anything. And diabetes seems to be one of the commonest reasons for silent MI, but there are other reasons too. So diabetes, basically, diabetes can affect any part of the body. One of the things that diabetes can cause is diabetic neuropathy. So the pain in the heart, we will not feel because of the diabetes neuropathy. So that is one of the reasons. So these are the clinical features of myocardial infarction. Now coming to the diagnosis. So for diagnosis, obviously, we usually consider these three aspects, which are the clinical features, troponins, that is a blood test, and ECG. So we already mentioned about the clinical features. Now we really have to do a differential diagnosis. When you hear the clinical features of the patient, obviously you have to consider whether it could be heartburn, whether this patient has got a history of heartburn. Sometimes what we do in the hospital is we'll give them a little bit of antacid. So if the antacid actually settles the chest pain, we think it's actually a bit of heartburn, which is actually related to acidity. Other things like pleuritis. Pleuritis is kind of a little bit of increased fluid in the pleura, which is the lung covering. So the two layers of the visceral and parietal layers of the pleura will rub each other, will cause a little bit of pain. Pericarditis, similarly, the layers of pericardium will rub each other in case of a little bit of increased fluid in the pericardium. Pneumonia, you know what the pneumonia is, that can actually cause chest pain. It could be just a muscle pain sometimes. How do we differentiate is, when the patient complains of chest pain, what we do is we ask the patient to just move, lift the arm, a little bit of like that. Then if the pain is increasing, it's usually a muscle pain because heart pain doesn't increase by movement. Costochondritis, the cartilage between the sternum and the ribs, from there, inflammation of that can cause chest pain like that. Injuries, if you had a previous CPR or something like that, or any kind of rib injury, you can have pain in the chest. So that kind of a differential diagnosis we have to do first of all. Anyway, otherwise clinical features could be suggestive of heart attack. Now, if there's a clinical features like that, obviously what we will be doing is we'll be doing some blood tests. Now, previously we used to do specific cardiac tests like CK, CKMB, all those kind of things. Recently, these days, we don't do that. We just do the troponins. And troponins, again, it has evolved significantly. And nowadays, we do high sensitivity troponins. So, these troponins, we have got different values. And I can't really tell you the value, what we use here. It may not be the same in India. Anyway, it may be the same, but I'll just tell you. So, what we do is, when we do the troponins, we say it should be around 14. 14 is kind of a cutoff value. Anything more than 14, we will consider. But we will repeat this test periodically at kind of 3 hours, 6 hours, 12 hours, like that we'll repeat. So if the troponins are high, if it is going higher and higher, or if there's significant variation, then we'll consider this patient is having a heart attack. And depending on what type of heart attacks, usually non-STEMI, which is a minor heart attack, troponins will not be that high. It will still be higher, but not too high. But if it is a STEMI, it's usually in thousands. Now, ECG, as we mentioned earlier, there can be an ST elevation if it is a STEMI. And if it's a non-STEMI, there won't be any ST elevation, but there can be ST depression or T-wave inversion, things like that. So that's how we diagnose MI. Now, once you feel that this patient is having a heart attack, obviously we have to consider the treatment. So treatment. So the gold standard treatment is still considered as a primary angioplasty or primary PCI. PCI means percutaneous coronary intervention, which actually has got many things in it. So angioplasty is the gold standard treatment. Now, if we can't do an angioplasty suddenly, obviously we have got other things that we can do is actually thrombolysis. Thrombolysis is basically dissolving the clot that is occluded in the coronary arteries using a drug. Usually we use here tenecteplase. So thrombolysis is a treatment. Angioplasty is another treatment. Now, if they do an angiogram and if they find an occlusion that cannot be treated with angioplasty, then obviously surgery, which is the bypass surgery, which is also called coronary artery bypass graft, that's a treatment. Now, after this angioplasty or after CABG or whatever you do, so obviously this patient should be on drugs as well. So in the immediate setup, when there's chest pain, what we do is we can just give glyceryl trinitrate or GTN, or people call it nitroglyceride. They come in tablet form as well as spray form that will actually dilate the arteries, will improve the blood supply to the heart. So that is something that we give in the immediate setup. We can give it as a spray or a tablet or even as an infusion. Now heparin is an anticoagulant, so that also we give to prevent any further clot formation. Now, if the patient had a procedure done, like an angioplasty or anything like that done, obviously we have to put the patient on further drugs, which are called DAPT or dual antiplatelet therapy, which actually includes aspirin and one of the other antiplatelets like clopidogrel or Plavix or ticagrelor or prasugrel, things like that. So that is actually to prevent any immediate stent thrombosis or restenosis. That means even if you put a stent in, I can actually show you a few pictures of what a stent is, if you do not know what that is. So if you put a stent in, obviously we have to protect that stent. There can be further occlusion in the stent. So to prevent that restenosis, we have to actually put them on some drugs. Also, there are a new type of drugs called drug-eluting stent, which actually will slow down the process of restenosis. But another problem is those stents will be kept exposed to the bloodstream for a longer time, and that actually can cause problems like stent thrombosis. On all kind of stents, actually, there can be stent thrombosis before it gets internalized into the artery. So to prevent that kind of things, we have to actually give this antiplatelet therapy with aspirin and one of the other drugs that I mentioned. So if you do not do that, if you do not take the drug properly, this stent itself will become the reason for another heart attack. We had a patient very recently. The patient was about 40 years old, and this patient actually was a little bit non-English speaking background. He was not from India. Usually Indians can understand English very well, but this patient actually was from another country. He did not speak English very well. So the nurses actually discharged this patient with a lot of explanation, but probably the patient did not understand. This patient actually had a stent put in, a drug-eluting stent put in, and the patient was discharged. But the patient didn't take this dual antiplatelet therapy properly. So what happened is, in a couple of days, actually, so all the patients who are discharged from our hospital, one of the cardiac rehabilitation nurses would give them a call just to see how they are. So this patient didn't take the phone. So she called again and again, but the patient did not answer. So a few days later, one of the friends of this patient actually reported this patient was found dead at home. So in autopsy, in postmortem, we found out this patient had actually had a stent thrombosis because the patient did not take this drug. So the treatment became the problem. So drugs are very important. Now, after discharge, this patient also should continue on some other drugs, which we call SAB, which is statins, aspirin, ACE inhibitors, and beta blockers. They are the drugs to prevent any future heart attack or also prevent any heart failure, which is actually a complication of heart attack. So just another thing I just wanted to tell you, not quite sure whether it is there in India or not. Maybe it is there, not quite sure. So, in a heart attack, the time is very critical. So what we call here as PAPA is actually pre-hospital assessment for primary angioplasty. That is PAPA. So what that is, so, okay, somebody in the community at home had a chest pain, or maybe he's having a heart attack, they call the ambulance. So as soon as the ambulance reaches the home, it's the patient's home. So what they do is they got an advanced ECG machine that actually can transmit the ECG to the hospital through Wi-Fi connection. So the ambulance people actually do an ECG of this patient and they transmit this ECG to the hospital and they will make a phone call also to the hospital. So in our hospital, in the emergency department, the casualty, there are computers set up to receive this kind of ECGs. And also the cardiologist on call on the particular day will also get this ECG to their phone. So suddenly this cardiologist and the people in the emergency department actually can see this ECG and interpret whether this patient is having a full thickness big STEMI heart attack or not. So if the patient is having a STEMI, they will tell the ambulance, okay, this patient is having a STEMI, bring the patient suddenly to the hospital, and also the hospital will be arranged. Suddenly they will actually give a call to the cath lab. You know what a cath lab is, where the angioplasty is done. So they'll call the cath lab, keep everything ready, and as soon as the patient comes to the hospital, the patient usually bypasses the emergency department, straight away go to the cath lab and get a primary angioplasty done, a stent is put in. So this, time is very critical in the management of heart attack. So this is a very effective, we've been having this for last 10 years. It actually has saved a lot of people. Otherwise, a lot of patients actually do not reach the hospital, and even if the patient reaches the hospital, they die. So a little bit about that angiogram, angioplasty, what we were talking about. Many of you may already know what that is, but if you do not know, that's why I'm actually going to tell you this thing. So basically looking into the heart, we're looking into the coronary arteries, what the problem is. That is what's called an angiogram. Angiogram is basically taking a record or a picture of the artery. Now, coronary angiogram, which is actually visualization of the coronary arteries through fluoroscopy. Fluoroscopy is like a continuous X-ray using a dye injected by cardiac catheterization. Looks at the coronary vessel anatomy, any abnormalities, any narrowings like that. Now, during angiogram, we can actually measure the pressures, oxygen saturations, cardiac output, everything from within the heart chambers. Angiogram may show normal findings, but if there's a lesion, it can be treated using either PCI or angioplasty, or the patient will be referred for coronary artery bypass grafting. So the catheter can be introduced through the groin or through an artery in the hand, which is the radial artery. That's a picture of a cath lab. Now, that's how the coronary artery will appear on the fluoroscopy or X-ray. So you can see different coronary arteries. What's marked with an arrow is actually just a bit of narrowing there. You can see there. Now, PCI, which I've been telling now, the percutaneous coronary artery intervention, coronary intervention PCI, that can be just a balloon angioplasty where they actually take a balloon to the occlusion. They keep it inflated for about 20 seconds, then deflate. So crush away that occlusion. Another thing is atherectomy, in which case the plaque or the fat deposit will be cut away. The other one is actually coronary stenting, in which we'll put a metal tube or a stent, and that actually will open up the artery. There are a lot of techniques actually. I don't know whether we have got time to explain everything. Actually, I'll show you a little video which probably can tell you a little bit more.
The heart is a beating muscle that continually pumps blood to the rest of the body. The coronary arteries supply the heart itself with the necessary oxygen and nutrients it needs to function effectively. Over time, and for a variety of reasons, fatty deposits called plaque can build up inside the arteries, clogging the passages and reducing their size. This buildup compromises the ability of the arteries to deliver oxygen and nutrients to the heart and body. Atherectomy is the general term for the group of procedures that open the clogged arteries by grinding or cutting away plaque buildup. During an atherectomy procedure, an incision is made into the femoral artery of the upper thigh. A guide wire is inserted into the artery and is threaded through the artery to the site of the blockage. A catheter, tipped with a specialized blade, is inserted along the guide wire. There are three main variations of an atherectomy procedure, each using a specific type of catheter tip. Rotational atherectomy, also called rotablator, is a common type of atherectomy. With this procedure, the catheter is tipped with a diamond burr that is guided to the blockage. While the burr spins at a very high speed, it grinds the hardened plaque into minute particles that can be safely eliminated by the body's own systems. Directional atherectomy is designed to remove buildup of softer plaque. After catheter insertion, a balloon is inflated along the catheter that pushes the blade toward the plaque. The blade cuts away the plaque and stores it in a special chamber. The balloon is then deflated, and the plaque is removed with the chamber as the catheter is withdrawn. Transluminal extraction is a vacuum device that not only uses spinning blades to cut away plaque, it also uses a tube which suctions the plaque through a vacuum that is attached to the catheter.
Hope at least some of you actually watched that animation. So this is how a stent looks like. Stent is deployed in the coronary arteries. It was taken to the coronary artery, mounted on a balloon. Once it is deployed, we actually take the balloon out. So angiogram, angioplasty, the two pictures here. I can actually bring my mouse to the occlusion here. So that's an occlusion there. And that occlusion has been stented. Now it's opened. So another one, actually, this was a patient that we had this last Friday actually. This patient had a massive heart attack and he actually went into cardiac arrest as well. So when we did the angiogram, I believe you can see this picture. So when you did the angiogram, so you can see this is the right coronary artery. So they put the dye through and then the dye is not going any past this point. So on the right coronary artery looks like it has been cut off. So what we found is a severe occlusion in the mid right coronary artery. Then we put a stent. Actually, we put 3 stents. We call it overlapping stents, one after the other. And we completely opened that area that was occluded. And now when we did an angiogram again, look at this picture now. The whole right coronary artery we can see on the angiogram. So it's amazing what this PCIs can do. Okay, now let's look a little bit about the prevention of heart attack. Obviously, as we mentioned, lifestyle modification, exercise, quit smoking, healthy eating, good sleep habits. So sleep habits, as we know now, we need to sleep 7 to 8 hours, minimum 7 hours. We don't have much time to sleep these days, but at least 7 hours of sleep is very important. 6 hours sleep and 7 hours sleep, big difference. If you sleep 6 hours or less, there's a possibility of about 1.7 to 1.8 times. So almost double the possibility. So, and in terms of exercise, what kind of exercise do you do? When you do exercise, you should really puff out. You should start, the panting. You should feel that, you're breathing a little bit faster, a moderate intensity breathing. So that kind of an exercise, we should do any kind of exercise like that. Should do at least 30 minutes, 30 minutes a day and most days in the week. So if you do that, it's reasonably enough. Now, obviously, drugs for dyslipidemia, that is increased fat in the blood, So for that, we need to be taking, we've got a tendency not to take drugs. That is true. That's good. But the problem is, if you do have dyslipidemia, we won't know when it is going up and down. So it's better start treatment early itself. So statins, like simvastatin, atorvastatin, things like that. So, and also if you've got diabetes, start treating it earlier. If you've got blood pressure, start treating it earlier. That's the prevention. Then early screening. So regular blood test. So I recommend if you are above 40 years of age, every year you should do blood tests for at least sugar and cholesterol. Then ECG. So again, here we've got a program like if you are above 45, the government will do all the free screening for you. That includes an ECG, blood test, everything. So ECG is actually good. When I talk about cardiac arrest, I'll tell you the importance of ECG again. But if you have had a heart attack, ECG will pick it up. So, and also if you've got any other problems related to that can cause a cardiac arrest, ECG will pick it up. So it's important to do an ECG properly. But when you do an ECG, it's very important that you should do the ECG properly. I still remember about 20-25 years ago, when I was taking LIC, Life Insurance Corporation of India, when I was going to take an LIC policy, it was a requirement that I should have had an ECG before. So I went to one of the hospitals in Muvattupuzha. I cannot quite remember which hospital it was, and they did an ECG for me, and the doctor said I got left ventricular hypertrophy. I was quite shocked. Anyway, I kind of had a memory that the girls, when they were doing the ECG on me, they actually didn't put the electrodes, the dots, in the correct place. So that is why the ECG showed left ventricular hypertrophy pattern. So anyway, I told this person I need to repeat the ECG. And this time I went to the same hospital, but I told them exactly where to put these electrodes, and they put in the correct place. And when they did the ECG again, it was normal. So it's important you get the ECG done at the right place by the right people. Then obviously angiogram. Angiogram, obviously we don't do angiogram normally, but only if you've got any symptoms like that, if you've got any angina, things like that, then it is good to do an angiogram. And of course they can do the treatment as well. Many people, we have found out they're having this coronary artery disease when we did angiogram for something else. And luckily they got treated. A massive heart attack could be prevented. Now CTCA is CT coronary angiogram, which is not an invasive angiogram, but a CT scanner actually can do an angiogram of the coronary arteries. They have to put a contrast medium into your veins, and you can actually see coronary arteries if there's a narrowing, anything like that. Another thing is again a CT technique, which is actually, what is a CT scan, don't you? So through a CT scan, you can actually do a coronary artery calcium scoring, which is actually finding out any calcium deposits in any kind of calcified kind of plaques, and we can predict the possibility of an upcoming heart attack. Now, important thing, if you have got minor symptoms, do not ignore, seek treatment. Sometimes, in the hospital, when we see patients with any kind of pain, anything, so if you've got any pain above the waist level, we actually look at this patient may be having a heart attack. But it's very difficult when you're at home, if you've got any pain above your waist level, to consider it like a heart attack is not that easy. But at least in the hospital, we do that. So, but definitely I can say if you've got any chest pain, please don't ignore it. We had a patient last week. This person was about 62 years old, and he was an extremely healthy person, a very fit man, do sports regularly, very active, lifestyle is really good. This man, he came to the hospital. When he came to the hospital, he came in a cardiac arrest, in a ventricular fibrillation cardiac arrest. And obviously we could defibrillate him, resuscitate him. He survived. And what we found out was massive heart attack. So he had a very big heart attack, an infralateral and also posterior wall MI, and a massive heart attack, extensive heart attack, leading to a cardiac arrest. So when we actually took the history, he said he had chest pain several times, which he ignored. So do not keep it for the last minute. I got a lot of pictures to show you. There's actually an MDCT, multi-detector CT scan, showing a coronary artery stenosis. Again, calcium scoring. You can see some white dots there, here and there. I'll just show you them with the mouse pointer. These are the calcium dots, or calcification, which is the calcium scoring. That's again another view of a three-dimensional view of the heart. Actually, you can play it, but again, when you look at the clock, we don't have much time, so I'm going to skip it. So I believe you understood a lot about heart attack. Now we'll proceed to cardiac arrest. So cardiac arrest, what is cardiac arrest as opposed to heart attack? They're completely different things. You know, a lot of times when there's a sudden death, it is actually cardiac arrest. People will simply say, hospitals will tell you, this patient had a heart attack. It may not be the case. It could be a cardiac arrest due to many other reasons. So cardiac arrest is basically when the heart arrests, when the heart stops pumping blood. So as we said earlier, it is often confused with heart attack. In fact, they're not the same at all. Now, heart attack is one of the leading causes of cardiac arrest. So clinically speaking, during the cardiac arrest, the heart is in one of the fatal arrhythmias, or we call them killer rhythms. These killer rhythms are either ventricular fibrillation or VF, ventricular tachycardia or VT, and VT can be either a conscious VT or unconscious or pulseless VT. What is called a cardiac arrest could be one of the pulseless VTs. Or another rhythm is pulseless electrical activity or PEA, which people used to call electromechanical dissociation or EMD earlier, and the other rhythm is asystole. So these are the 4 killer rhythms that can result in a heart attack, in a cardiac arrest. Now, the causes of cardiac arrest. There are many causes of cardiac arrest. So obviously, heart attack is one of the biggest causes. There are many causes listed here. This slide is not everything. I've got 2 more other slides explaining the causes of cardiac arrest. So I'll very briefly explain to you what they are. Now, heart attack, as we learned, pulmonary embolism is basically a clot in the arteries taking the blood to the lungs. Hypoxia, severe drop in oxygen levels in the blood. Massive bleeding. Hypokalemia, less potassium in the blood, can be due to some of the medications that you take. Have you probably heard of Lasix, furosemide, one of the medications that we give in heart failure, that actually can cause to lose a lot of potassium from the body. So that can cause hypokalemia. A lot of other reasons too. Then cardiac tamponade, there's a lot of fluid in the sac around the heart. That's the simplest explanation of cardiac tamponade. That will kind of squeeze the heart, will not let it fill up again. So that actually can suddenly stop the heart pumping, can lead to cardiac arrest. That's a common finding, not a common finding, but it can actually happen after cardiac surgery, any kind of chest injury, pericarditis, aortic dissection, etc. Complete heart block. You've heard of heart block probably. So one type of heart block is complete heart block that actually can lead to, it will start off like severe bradycardia or severe slow heart rate, then slowly it can actually lead to a pause in the heart rhythm. So that actually can cause stop the heart. Other causes, sometimes the medicines that we take, suppose you're in the hospital and you may be on a morphine infusion. Morphine is a painkiller, and we may be on a morphine infusion for pain. But if excess of that can actually cause heart attack. Cardiac arrest. Then other things like other drugs like digoxin. Digoxin, when you take digoxin, there may be many people who are taking digoxin for minor arrhythmias like atrial fibrillation. But if they're not being monitored carefully, we have seen patients who came with severe like arrhythmias like ventricular tachycardia and fibrillation secondary to digoxin toxicity. Another thing, actually, there are a lot of drugs that we commonly take like flecainide, sotalol, amiodarone, things like that. Or even the new COVID drug, hydroxychloroquine, or that's actually a malaria drug, as you know. They all can actually cause something called QT prolongation. QT interval is a finding in the ECG that can be prolonged. That can cause cardiac arrest as well. Tension pneumothorax, that is basically air in the sac around the lungs, which constantly keep on increasing. That is called tension pneumothorax. That also can squeeze the heart, stop the heart pumping. Acute myocarditis, inflammation of the muscle of the heart. Electrocution actually can stop our heart. Brugada syndrome. Brugada syndrome is actually, you probably have heard of Brugada syndrome. Not very common in India, but there are a lot of Asians like Thailand, Philippines, a lot of countries. They got prevalence of Brugada syndrome. There are cases reported in India as well. And what is Brugada syndrome? Brugada syndrome runs in families. It's actually a gene mutation. So the gene mutation actually can cause a particular ECG pattern, and these patients actually tend to develop severe fatal arrhythmias like ventricular fibrillation. So I'll just tell you a brief description about a patient who was reported from Visakhapatnam in India. I happened to read this. This patient actually was, this is a 19-year-old boy. He was admitted in the hospital with a high-grade fever, and they actually made a clinical impression of malaria. Anyway, a routine ECG that they took showed some strange pattern. So they referred this patient for cardiology, and they actually diagnosed Brugada syndrome. So Brugada syndrome actually, there's a classic ECG pattern that we can see in Brugada syndrome. If you're interested, I can talk to you about that later. Now, this is a disorder that actually is characterized by sudden death. Now, patients with Brugada syndrome are prone to develop ventricular tachyarrhythmias, and it can lead to cardiac arrest and usually a sudden cardiac death. So it is common more in men aged 30 to 50 years, but there is no discrimination between the age. There can be any age that can actually, these Brugada syndrome patients can be found in any age. Now, as I said, the reason for Brugada syndrome is actually a mutation in a gene. Now, what's the treatment? There's no treatment because it's a gene mutation. We cannot fix that. So only thing that we can do is, if you ever heard of any sudden cardiac death in your family, you have to undergo the screening. All the family members actually have to undergo the screening. There are a few drugs that actually can precipitate this problem. So they can do those kind of drug tests, or actually they can do an ECG. This ECG actually can show this particular classic feature of Brugada syndrome. And if there is Brugada syndrome, then the only treatment that we can do is we can actually give this patient an implantable defibrillator, which we call AICD, or automatic implantable cardiac defibrillator, or cardioverter defibrillator. So this defibrillator, a little device that can sit just under your skin, then actually can pick up any kind of killer rhythms, mainly this ventricular fibrillation or ventricular tachycardia, and give you a shock suddenly when it is picked up. So the patient will be saved from dying. Long QT syndrome is also a problem that exists in families. QT interval is a particular finding in ECG that can be prolonged, and that can lead to ventricular fibrillation and other arrhythmias like that. Pre-excitation syndrome, that is actually presence of an accessory bundle between the atria and the ventricles of the heart that actually can cause a problem. Generally, this is also called WPW, or Wolff-Parkinson-White syndrome. Common problems are like supraventricular arrhythmias, atrial fibrillation, things like that. But sometimes, just imagine, if I really want to explain, there's a lot to explain, but quickly speaking, or shortly speaking, what will happen is, if a patient is having a minor arrhythmia like an atrial fibrillation, if there's the presence of an extra bundle connecting between atria and the ventricle, that actually can travel down to the ventricle and make a ventricular fibrillation and kill the patient. That's the simplest explanation I can give you about that. Then other causes of cardiac arrest, cardiomyopathies, dilated cardiomyopathy, hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, they all cause cardiac arrest. Severe heart failure can cause ventricular arrhythmias, congenital heart defects, commotio cordis. Have you heard of commotio cordis? It's not a common thing, but just want to tell you what that is. I'll tell you a very brief story that happened in Australia. So a 14-year-old boy, he was struck in the chest with a softball during a school sports carnival. He fell unconscious. They called ambulance. When the ambulance arrived, the sports coach was already giving CPR. The ambulance, when they arrived, they picked up ventricular fibrillation. Then they attempted defibrillation, but failed to revert back. The patient was taken to the hospital, and by the time they reached the hospital, it was already about 40 minutes after the cardiac arrest. They administered all the standard drugs. They defibrillated another 8 times without any success. Family was informed. Sadly, the patient, that 14-year-old boy, was declared deceased. So, from autopsy, the heart was perfectly normal. There was no other issues. Then the forensic pathologist puts the cause of the death down to commotio cordis. So what is commotio cordis? It's a ventricular fibrillation and sudden death triggered by a blow to the chest. So it actually comes from a commotion chord is actually coming from a Latin word meaning agitation of the heart. All that we can do is prevention. So, well, to prevent the patient going to go into a sudden death from this cardiac arrest, for that we have to treat the cardiac arrest quickly. So in all the sports places, they should actually keep a defibrillator. Also teach the sport coaches proper CPR techniques. Teach the players how to deflect fast balls using shoulder rather than the chest. Teach the public about the danger of chest blow. So something important. Now the next little question, can video games affect your heart? Really? Now video games, not usually, but it can affect the heart. So generally what they say is, if you've got any underlying problems, if you've got any underlying issues with the heart, if you've got already, there's a possibility that can lead to cardiac arrest, then video games actually can precipitate cardiac arrest, particularly intense video games like war games. They have done some studies. So in all those studies, people playing war games, they found it could actually put the patient to unconsciousness, and they found the patient was in cardiac arrest. People were in cardiac arrest. So the video game is actually not very good for you. It can shoot up the blood pressure. It can precipitate even cardiac arrest if you do have a pre-existing cause, which probably you may not be aware of. Now, treatment of cardiac arrest, as you know, it is cardiopulmonary resuscitation or CPR. Now, when I mention about CPR, it is very, very important that you should know how to perform CPR correctly. There are a lot of studies done. So the studies have shown that CPR performed by a trained person has much more been effective than by an untrained person. So anyone can do CPR. Nowadays, I don't think there's anyone who doesn't know how to do CPR, but CPR performed by a trained person, it has actually saved lives. So make sure you know how to do CPR properly. There are three important aspects when you do CPR, the chest compressions that I'm talking about. There are three things. The rate should be about 100 to 120 compressions per minute. The depth, 1/3 of the chest, 1/3 of the anterior posterior diameter of the chest. And make sure you come back fully, recoil, that many people do not do. So if you do not let your hand come back fully, then we are not letting the heart filling up again. So we are bagging an empty heart or squeezing an empty heart. So these three things, the rate, depth, and recoil, they're very important in CPR. So learn to do CPR properly. Then make sure you got a defibrillator. Many cardiac arrest rhythms like ventricular fibrillation, if you do not defibrillate, there's no chance of survival. Even if you do CPR for a long time, the patient may not survive if you do not defibrillate in time. And as all of you may know, our brain will not survive more than 5 minutes in cardiac arrest. So we may be able to resuscitate this patient back to life, but this patient will be brain dead. No point. So make sure you got a defibrillator in most of the places. In big places like shopping complex and places like that, you need to have an AED. At least you should know where an AED is available. Do you know where is your nearest AED? Most of you may not know. In here, we all know. We have got an app in our phones that actually can tell us where the next nearest AED is. There is an app that can be downloaded from App Store and Google Play called Staying Alive. They claim that this app actually provides defibrillator mapping and is available in about 18 languages, and it claims that it maps over 120,000 defibrillators across the world. I haven't tried that before, but you can try. You can download it and see whether it actually is mapping AEDs around you. So other thing is basically, so in terms of, I was talking about CPR now. So chest compression, in the CPR itself, chest compression is very important. Then ventilation, then defibrillation. Then there are drugs. And we can actually give a lot of drugs. They are called cardiac arrest drugs. We tried adrenaline, amiodarone, things like that. Then of course we'll think about the causes, what actually caused the cardiac arrest, and we'll treat the cause. So that is how we treat cardiac arrest. Cardiac arrest cannot be treated in a small hospital. Cardiac arrest, if there's a cardiac arrest, obviously you have to start the chest compression as early as possible. But we should get the advanced treatment as soon as possible. Now it's very, very important, particularly in the context of India or other countries like that, where there's a lot of traffic. I've seen, when I was in India, I've seen ambulances struggling to get through the traffic and to reach a hospital. In spite of making the loud sirens and honking and everything, there's no way, there's no room for the ambulance to go through. So it's very, very important that we need to start this intervention like CPR and having a defibrillator, all those kind of things. I believe in India also ambulances have defibrillators. Now, how to prevent cardiac arrest? As we know, identify and treat the causes early. Then how can we identify the cause? If you got some strange feelings in your chest, obviously go to and see a cardiologist. There are a lot of things that we can do. Things like obviously do an ECG, put you on a cardiac monitor, and if you can't find something there, then maybe send you home with the Holter monitor. Still can't find something, then maybe you can be sent with a loop recorder that can actually stay in your body for almost a year or even more, and then continuously monitor your heart. That actually can pick up any kind of abnormal heart rhythms. Electrophysiology study is an invasive study which actually can find out any abnormalities in the heart rhythms. Then obviously the AICD or automatic implantable cardioverter defibrillator implantation, if you think there's a cause but it is not treatable. That's a picture of loop recorder. So just another picture of how an AICD or pacemaker is implanted. Pacemaker and AICD is completely different things. And I think that's the end of that presentation.
Thank you, Anil sir.
Thank you, Annie.
Thank you, Anil sir. It was wonderful. I think there are many questions which have come up in the chat box. Should I read it for you or the audience?
Maybe you can read it for me, Annie. Either way, I don't mind either way.
Okay. The first question which I see right now is, if there is any problem after putting the stent, how do we know that?
Okay, so probably you heard me saying about a particular patient that we had recently. That patient was just a 40-year-old guy who had a stent put in, but after going home, he had another heart attack and he passed away at home. So that is not very good. So other than that, if you do take your drugs properly, the drugs that is given from the hospital, which is actually called, we call it here DAPT or dual antiplatelet therapy, that includes aspirin and one of the other blood thinners like clopidogrel and things like that. And of course, you've got other drugs. If you take them regularly, if you take them strictly, and if you look after yourself, looking after your diet and all those kind of things, you may not get another heart attack like that. Well, we can't still say, you still may get. Just like any other heart attack, the symptoms will be like that. So even if you had a stent, it doesn't mean that you won't get another heart attack. That particular blood vessel that has been opened up probably may not cause any problem in the near future, but there can be other blood vessels too. So prevention is the key. Once you had a heart attack, it's a big warning sign. You do have a problem, you have to fix it. You have to change your lifestyle. So if you look after yourself, you probably won't get anything. But if you do get another heart attack, the symptoms are not different, just like any other heart attack. As I mentioned, chest pain and all the other symptoms of the heart attack. Does that answer the question?
So, is Dr. Sangeeta Tiwari present there? Dr. Sangeeta Tiwari is there. It was her question, first question. Should I go for the second question? Are you satisfied with the answer?
Yes, Yes, thank you very much.
That's okay. Thanks.
Should I go for the second question?
Yes, I have put another question also.
Okay, if an artery has, I'm going for that. If an artery has 70 to 75% blockage, does it need immediate putting of a stent?
Well, we do put a stent for that. If you've got a 70 to 75% block, we do put a stent. That's what we do.
Okay.
Hope Sangeeta, ma'am, your question is answered properly. Satisfied?
Yes. Thank you so much.
Yeah.
Sir,
you want to ask anything else?
No. I want to only say that the talk was very good and I just listened it very carefully, and you have given such a basic, very good knowledge of the very common problem. Thank you so much.
Thank you.
Okay. Thank you, Sankita. And going for the next question. How risky the life with stent? Any restrictions on food and exercise?
Sorry, say that question again.
How risky the life with a stent?
There's no risk.
If a stent is there in the body, how risky the life?
No, there's no real problems actually. There's no real problems. Most of these stents are nowadays are absolutely fine. Like, you can have MRI with that. Even though there's a metal tube inside your body, there's no issues really. As long as you take
Now, rest of the question is also there.
Yeah.
One more part is there.
Yeah.
Any restrictions on food and exercise?
No, not at all.
Okay.
Not at all. But you need to take the drugs, that is to protect that stent. Otherwise, the stent will cause another heart attack.
Ma'am Jovita Lindsay, are you listening it?
Yes, ma'am. Hi.
So,
Yes,
are you satisfied with the answer?
Yes, I am fine with it.
Okay,
Thank
thank
you, sir. Presentation is very.
Can I ask one more question?
Please,
Can I
ma'am.
ask one more question?
We can ask.
Sir, how do we differentiate between the acidity and the heart problem? Because it is so much interfering. Because before heart attack, many patients say that yes, we are having acidity. They keep treating acidity. So, is there any fine differentiation between these two problems? Means how to differentiate between these two?
Sometimes,
I think
Whether it is
Sankita has come back.
yeah, sometimes we can't differentiate, unfortunately. But most of the time, what we do is, well, this patient, whether they have got any other symptoms of, what we call as the GORD or gastroesophageal reflux disease. You heard of that, GORD, that term, gastroesophageal reflux disease, which is we call popularly as acidity. So if the patient has got a problem like that, we may have other symptoms, they may have, depending on where the problem is, sometimes soon after having food, they get this kind of heartburn-like feeling. And it usually starts from the stomach and then it goes up and up. So that kind of things. Or sometimes they can be hunger pains, like when the patient is starving, they can have this pain. So this patient probably already know that they are prone to get this kind of gas pains. So that is one of the things that we can differentiate. But the nature of the pain, classically, the heart pain is different, very different from the gas pain. So gas pain, as you know, is kind of like a dull ache that is coming up from the stomach, going up to your throat, that kind of a feeling like heartburn. But the cardiac pain is very different. It's actually located right beneath your sternum, beneath your breastbone, and you really feel like your heart is kind of crushing. It's like a crushing, squeezing pain. That is a classic difference. But unfortunately, sometimes that classic difference may not be there. So, yeah, if there's any pain like that, particularly if you've got associated symptoms like these things, like the sweating, sometimes your heartbeat will actually go down, you feel weak, you feel tired, all those kind of things. Sometimes you feel nausea and vomiting. Those kind of things may not be there in pain from acidity. So that's one thing. And another thing, what we do in the hospital is we actually, we do an ECG anyway, but along with that, we give some antacids. And the antacids will settle the gas pain, but it will not touch the heart pain. So that is something that you can do.
Okay.
Yeah.
Okay. So that means there is no relation between. Suppose a patient has a heart problem. So is it like that whenever there is acidity, it will increase the problem, and when there is no acidity, he will feel normal? Is these two have any relation?
No, they don't have any connection at all.
Okay.
Yeah.
So acidity or no acidity has no effect on this feeling comfortable or not comfortable.
No, nothing to do with it. If a patient has got acidity, obviously the patient may have gas pain, which we call usually the acidity pain, but it has got nothing to do with the heart pain at all. Now, another thing, what we can do is, if you got that kind of a fear, is actually in my house, actually, I keep a GTN, like a nitroglycerin spray. Because we are Indians, we got this high tendency of heart attack. And if you do have a family history of heart attack in your, we always are prone. I do monitor my blood and everything, but I do have a GTN spray in my house. So you know what I mean? So what we sometimes can do is, if you get a pain in your chest, if you give this one shot of the spray, and that spray is actually quenching your chest pain, it's actually from the heart. GTN spray will not treat a gas pain. But another thing is, if you're feeling dizzy or anything like that, you should not use that spray at all. That's another thing, warning. Because if your blood pressure is lower than 100, then if you take the spray, that actually can make you collapsed.
Okay. So can you name that spray again? I didn't understand. Can you write them?
Okay, it is called glyceryl trinitrate, GTN, or it simply say nitroglycerin.
GTL.
Sorry, spelling mistake. Nitroglycerin.
Okay, nitroglycerin.
Or another term is GTN, which is glyceryl trinitrate. Glyceryl
trinitrate.
Yeah, trinitrate.
Okay.
Like, don't simply start using this, but only if you've got a history of heart attack in your family, and of course, if you're an Indian, there's a possibility always. But if you keep checking your blood cholesterol and everything, and if you keep it properly, it's not a problem usually.
Okay.
Yeah. Because in the hospital, what we do is, before giving this GTN, we always check the patient's blood pressure. The blood pressure is less than 100, we don't give it.
Okay.
Yeah.
So if you get that spray, then that feeling will subside. What do you want to say?
If that spray subsides your pain, that is actually more than likely it is from the heart. If it is just a gas pain, it won't touch the gas pain. You will still have the pain.
Okay.
Now, one more issue there is, if you've got a massive heart attack going on, this spray still may not subside the pain, but you're actually going into a heart attack. You have to go to the hospital quickly.
Okay. Thank you, sir. Thank you.
You're welcome.
Okay, should I go for the next question? It's from Madam Manju Bashini. The question is, why small children are also getting cardiac arrest?
Yeah. To be honest, small children are more prone to respiratory arrest than cardiac arrest. So cardiac arrest is actually a rare finding in small children, unless they have got a congenital heart disease. Congenital heart disease means they can be born with some kind of structural anomalies in the heart. So those children can actually get cardiac arrest. But otherwise, generally, children are not that prone to cardiac arrest. Unless, I told you earlier, a child of 14-year-old had a commotio cordis. There is a blow in the chest that actually led to cardiac arrest. So things like that can happen. And otherwise, mostly it's a congenital anomaly. I remember one of my old colleagues in India, his child actually had something called Al-Kappa. Al-Kappa is actually one of the congenital heart disease. This is called anomalous left coronary artery from the pulmonary artery. So the heart's arteries should start from the big aorta, which is actually carrying oxygenated blood. But this child's cardiac arteries started from pulmonary artery, which actually carries deoxygenated blood. So the heart was actually getting deoxygenated blood. So you know how it is happening. So this obviously child would be getting a heart attack. So mostly children will get cardiac arrest only if they got congenital heart disease. Otherwise, it is very, very rare.
Okay, thank you, sir. So, Madam Anju, are you listening? Is the answer okay? Don't know whether she's there or not. Then one more. The next question, I think. Okay, you are welcome.
Thank you so much, ma'am.
From where are you talking? Joining? Madam Anju?
Ma'am, Department of Zoology.
From?
Ma'am, Ponneri Government College. Ponneri Government College.
Okay, okay, ma'am. The next question is, the next question I think you have already answered, sir. How can we distinguish heartburn and chest pain?
Oh, yeah.
You have already answered that. Then one more question that was from Preeti Paulos. Then the next question is from Mr. Mallikarjun. I think that also you have answered. How to differentiate heart pain from other pain?
Oh, yeah.
So are they listening? You want the answer again?
Yeah.
Okay.
Just to add to that, Annie, how to differentiate heart pain from other pain. There are a lot of things that we do. Like I think in the differential diagnosis earlier in one of the slides that I presented, I mentioned that there are some things that we do, this heart pain from other pain. The other pain can be, as you said, gas pain, which you already said. Then otherwise, it could be just a muscle pain. The muscle pain, what we do is we actually ask the person to move, move their arm, like that. When they move, if the pain is getting worse, obviously it is not usually heart pain. Now, if the pain is due to pneumonia or pleuritis and things like that coming from the lungs, what we ask the person to do is just breathe in and out strongly. Now, if they do take a deep breath in and out, and then usually if the pain is getting worse, then it is usually from the lungs, not from the heart. So things like that to differentiate. Then sometimes if it is a pain from the costochondritis and things like that, we usually give a little bit of pressure on the chest, and then the pain will increase. So heart pain is usually, if it is from the heart attack or angina, that pain will not have any change by this kind of maneuvers.
Okay. Okay, sir. Mallikarjun, sir. Okay. Then one more question from him. Is pranayam a preventive measure of cardiac disease?
I really do not know. I don't even know what pranayam is. I believe it's a breathing exercise. Is it pranayam?
Yes.
Yeah, it's a breathing exercise. I don't think it's got anything to do with prevention of heart disease. At least in modern medicine, we do not really. Obviously, it's a breathing exercise, so obviously it will keep you healthy. It's good for your lungs. In that way, it may have an indirect effect, but not a direct effect on the heart.
Okay. Should I go for the next question?
Yeah.
Mr. Mallikarjun is asking for the name of that app. What you were saying?
That is
app.
That is an AED location app. AED locating app. It's called Staying Alive. I'll probably type it here. Yeah, I haven't downloaded this app myself, so just try it, because in Australia we've got a lot of other apps that actually can tell you where the AED's locations are. And I believe I didn't really tell you what exactly AED means. It is an automatic external defibrillator, AED. It's a very easy to use device, automatic external defibrillator. It's got only two buttons, just a power on button and a shock button. So as soon as you connect it to the patient's body, it will tell you if it is to be shocked or not. And if it is to be shocked, if the cardiac arrest is to be shocked, it will tell you to press the shock button. That's it. It's very easy to use. It's about 3,500 Australian dollars, which is about something like 150,000 Indian rupees, I think. But it's important to have that device. if you, particularly in India, like, where the ambulances will take a long time to reach the incident site. And this particular app, Staying Alive, is actually, they claim to tell you the nearest AED location. I haven't tried it myself, but just try it.
Okay, sir. The next question is why small children getting heart arrest? That is already answered, I think.
Yeah.
Why small children getting heart arrest? And the next question, what precautions can be taken for stent?
Taken for stent means what? I think what this person means is, if you have a stent put in, then what else?
If you have a stent, what are the precautions to be taken?
Yeah, only the drugs. Only the drugs. And of course, look, change your lifestyle, because why did you need a stent, first of all? Because you had a heart attack. So you don't want more and more stents to put in your body. So if you had a stent, it's a big warning sign. Change your lifestyle, keep monitoring yourself, do all the screening that you can do, and take the medications correctly.
Okay. Then there is a statement that there is a condition where people having placed with the stent getting heart attack. I have seen, personally seen 3 people. That is a comment, and I think you have already discussed that. One stent, though there is stent, they are getting heart attack.
Obviously, yeah, because if the person has got predisposing causes that is causing heart attack, one stent is actually has opened up one occlusion in one coronary artery. So there are other coronary arteries, there are other occlusions probably, and if they do not look after themselves, there may be more and more new occlusions coming up. They can have heart attacks again.
Okay. Then another question from Pushpakshi Bora. Is there any role of Ayurveda in heart ailment? Probably this person wants to know if they take so much of Ayurvedic medicine. I mean, is there any problem? That is what I think they want to ask. Bora, are you listening it?
Yes, I'm listening.
Yeah, I really do not know how to comment on that, because there may be or may not be, but I would suggest for me, I have also taken a lot of Ayurvedic treatments earlier in my life. I usually go to anything natural medicine, Ayurvedic or homeopathic or any other natural medicine, when I do not have a treatment in allopathy. So this is my personal view, okay, by the way, it's not a direct or correct answer, but it's my personal view. If I do not have a treatment in allopathy, obviously there are a lot of diseases that has got no treatment in allopathy. Those things, obviously, I will start taking other natural medicines. Particularly skin conditions, homeopathy is really good, I heard. And a lot of problems, actually, joint diseases and things like that, Ayurveda is really good, I heard. But for heart disease, you do have a definite treatment, definite proven research-based treatment in allopathy. Why do you think about anything else?
Okay. Are you satisfied with the answer or want to ask something else?
No, it's fine. Thank you.
From where are you talking? Which part
Assam.
of?
From
Okay.
Assam. Okay.
Okay. Thank you so much.
Yeah, thank you.
The next question is carbohydrate food or fatty food, which is more injurious to heart?
Can't really comment on that. Carbohydrate is as bad as fat, I would say, because carbohydrate also will get converted into fat and get deposited in the body. So, carbohydrate is not better than fat, or I would say both are bad.
Okay.
And I've heard that, people actually when take, because we have got a natural tendency, Indians have got a natural tendency to take a lot of carbohydrates. So that actually make you obese, make you diabetic, and diabetes has got a direct connection with the heart disease. So carbohydrates, if you are taking the same amount that we usually take, in here, they always say, if you take carbohydrate, if you take particularly rice, that's a staple food in India, only 1/4 of the plate, there should be rice. The rest should be curries, like vegetables and things like that. But if you do cooking like in Indian style, to fill the plate with all the curries, keeping only 1/4 of that rice will be too difficult. You'll have to constantly cooking. Every hour you should be cooking. So, but if you can take raw vegetables, raw fruits and things like that, then that the carbohydrate, keep the carbohydrate only a 1/4 of the plate, and the rest vegetables, meat, things like that, or fish, all those kind of things.
Okay, thank you. Are you satisfied? Okay. The next question is from Chandini C. Okay, please go for.
What about keto diet, sir? Because now keto diet where 75% fat is included nowadays, it's trending in Facebook and all. Keto diet.
I think it is just a fat burning diet or just to lose weight. I don't really think anything to do with the heart. It's not healthy for you. That's what I have heard anyway.
Fine.
Okay, should I go for the next question? Are you tired?
It's okay. You can keep asking. That's fine.
The next question is, what are the precautions should a diabetic patient to be taken to avoid silent myocardial infarction?
The main thing is to treat diabetes. The silent MI is actually, silent MI may have other reasons too, which is not completely understood yet. So one of the reasons for silent MI, which we have also seen a lot of cases here in our hospital, people who are diabetic, when they had heart attack, they didn't even know. And that is a very common thing in diabetic people that I have seen here in our hospital. So if a patient is having diabetes, that diabetes can lead to complications, like many complications, and one of the complications is called diabetic neuropathy. So when there's a diabetic neuropathy, that is actually what is causing the lack of sensation of the pain from the heart. So if you have got a diabetes, you have to start treating it early before going into complications like diabetic neuropathy. So find it out early. Particularly if you've got family history of diabetes, and if you haven't done a blood test, definitely go for a blood test, get it checked every year, look after yourself, and if you have diabetes, start treating it early before leading to that complication of diabetic neuropathy.
Okay, should I go to the next question? That is from Christina Mary. She asks, could you please tell about further implications of COVID-19 in cardiovascular system? Will it lead to cardiac arrest?
Okay.
She wants to know that.
Okay. COVID-19 is still being studied, as you know. We don't know everything in COVID-19. And the pattern is also very different. The pattern, how COVID-19 is impacting patients, people in India is different to America and Australia. So every place it is different. In Australia, it is quite mild. So we don't know why. Somehow we are just saved. So COVID-19 is still being studied. And just to let you know, some of the Australian studies on COVID-19, some of the Australian researchers and doctors, what they found out is, again, it's kind of an assumption, because we don't have enough cases to study on. So what they have found out is COVID-19 actually can cause microemboli, like, small blood clots in the body that actually can cause heart attack, pulmonary embolism, stroke, and those kind of things. And also some other studies showed that this COVID-19 actually can cause, it is a virus causing, isn't it? So it can actually cause myocarditis, viral myocarditis, COVID-19 myocarditis, that actually can cause cardiac arrest if it's an acute stage, or it can actually cause heart failure and things like that.
Thank you.
You're welcome.
Okay. And the next question, everybody is appreciating your seminar. I'm not reading it right now. At the end, I'll read.
That's all right.
I'll copy and give you.
Yeah.
The next one is, some people have a lipoma.
Lipoma, yeah.
Lipoma, can it cause cardiac arrest?
No. Now, lipomas, usually, lipoma is, if people do not know what lipoma is, actually I got a lipoma on my body as well. So lipoma is a little fat nodule. When you feel on your skin, you can actually feel like something like a little tumor. So people may think what that is. And when you actually touch it and move it, it is usually mobile. It is movable. It is a lipoma. It is just harmless. I got my lipoma I'm just 48 now. I think I've got it maybe since I know about it. So maybe last 30 years I got this lipoma. It's fine. It won't cause a heart attack.
just a minute. I just keep. Okay. The next question is from Christy. Can massive exercise or loss of more weight lead to heart attack?
Well, we don't want to lose too much weight. It's actually kind of a beauty concept, I think, weighing too much weight and becoming slim like a stick. That is not healthy, not just causing heart attack, but it's not healthy. It's not healthy at all. Now, I have had some patients, not many, but 1 or 2 patients who had actually heart attack while they were doing exercise. So obviously exercise, if it is too much, actually can cause heart attack. Particularly, say, just think you have got a narrowed coronary artery, narrowed artery that is supplying blood to the heart already there. So if you're doing exercise, you're making a lot of stress on the heart, right? So obviously, when you are not exercising, the blood supply that your heart was getting was enough, kind of enough. But now we are exercising very vigorously, that actually, of course, can produce another heart attack. So before you do exercise, just like, all exercise people say, before you do any kind of exercise, make sure you're medically fit to do that exercise. If you have got a pre-existing problem, it can cause a heart attack. But if you're a completely healthy man, if you've got a completely normal coronary arteries, no issues with your heart at all, you don't have any congenital heart disease at all, that's absolutely fine doing exercise. But again, anything too much is not good.
Okay. Lot many questions are there. I was just searching. Oh my God. Okay. In between, I must appreciate you. All have written such an amazing talk and wonderful talk and all these things. And I'm also proud that I'm your friend. And we could arrange. And thank you so much for answering all these questions. And the next question is there any chance to have heart attacks as hereditary? You have already talked about it.
Yeah, definitely. They say double if you've got a family history of heart attack. Now, one more thing, what we usually ask patients is if anyone is telling you, okay, I've got a family history of heart attack, then obviously we'll ask them whether they are your immediate relatives. That is one of the questions to ask. Then another thing is, when did they get the heart attack? They've got a heart attack, say, when they were 80 years old, probably that's all right. But if they had heart attack early in their life, it is more risky.
Okay. The next question, explain about the multiple heart attack.
Multiple heart attack means,
Hello?
What do you mean by that? Heart attack one after the other? Or?
Yeah, madam.
Sir, please say what do you want to know from multiple heart attack?
Yeah, because many times we heard in hospitals he had multiple heart attacks.
So usually, multiple heart attacks, people sometimes say multiple blocks or multivessel disease and things like that. So if you have got, maybe we can explain many different ways. So if you have got a block in multiple arteries of the heart, for example, if you got, say, as you know, probably you got our coronary arteries, basically the right and left coronary arteries mainly, and of course the left coronary artery can have, again, many branches. The main 2 branches are left circumflex artery and the left anterior descending artery, and the right coronary artery also has got branches like that. And you can have blocks in any of these branches, and all these branches of these coronary arteries are supplying to different parts of the heart, as you know. So one of the commonest is actually anterior wall MI, which is actually the anterior wall of the left ventricle, which is supplied by the LAD, the left anterior descending artery. That is one of the commonest area of heart attack, but it can be in other areas like the inferior wall or lateral wall or posterior wall. So if you say a multiple heart attack, I would say what they mean is there is an extensive heart attack that is affecting multiple walls of the heart.
Does a person, this is from Adra M. Naya, does a person have low BP like 100, 100, then 60?
Yeah.
Is there any problem?
So obviously there are many girls and boys, and particularly young people have got low blood pressure, 100 over 60. What we usually hear as the normal blood pressure, which is 120 over 80, probably if that is what you mean. So that is just a textbook picture.
It is 60.
Yeah. I know. That's a textbook picture. That is 120 over 80 when people say. So, the two components in blood pressure, the systolic blood pressure and the diastolic blood pressure. The systolic blood pressure can be anything from 100 to 140. And the diastolic blood pressure can be anything from, say, 50 to 80 or, like that. So basically, if your blood pressure is 100 to over 60, it is completely normal. But if you do have any other signs, like if you feel overly tired or if you have got any other issues, then obviously you get it checked up. Otherwise, 100 over 60 is a perfect blood pressure.
The next question was from Ms. Jovita. I think I was just going through. Is there, it was all about how much women are prone to heart attack after menopause. That was the question.
Yeah, obviously they have lost that estrogen protection. When obviously postmenopausal women are more prone to heart attack. But we can't do anything about it, can we? Some people are actually taking hormone replacement, but hormone replacement has got its own issues. So it would be, definitely get it checked up. I would say if you're a postmenopausal woman, then obviously you have to do your screening more periodically, more frequently than before menopause. Like, every year you should do your blood test and all those kind of things. Yeah, they do have a bit more possibility for heart attack before, compared to premenopausal time.
Then Pushpakshi Bora has asked one question. Is it true that an overweight dog develops heart disease? I think it is a question from to the veterinary science, but
I'm not quite sure. Obviously animals they behave very much similar to human beings. If the dog has got cholesterol, if the dog is just a big dog, maybe it's fine, but maybe the dog has got cholesterol, obviously the dog is also prone for heart attack, I guess. I'm not quite sure. I'm just guessing.
So there is one more question from Meera Menon. Many at times we have come across many cases where the block is around 90%.
Yeah.
Where the patient is recommended for immediate surgery.
Yes.
But often these patients go for alternative therapies and seems to be doing well. How do we account for this?
So what do you mean by the alternative therapy?
That she hasn't mentioned. Miss Meera Menon, are you there?
Yes, ma'am, I'm here.
So
you can.
So what is the alternative
explain.
therapy?
I mean, you
What
can
do you mean by that?
have interaction.
Actually, I've been, sir, I'm a clinical endocrinologist. I've been tracking a few patients who have shown 90 to 94% block.
Yeah.
And these guys going for a lot of alternate in the sense either Ayurveda or homeopathy, anything except for allopathy. And I have hard time convincing them that you shouldn't be doing it. But then I have known patients for past 8-9 years. They don't seem to be having any of those problems which actually I would associate with, having a block of 90%.
Yeah.
So I'm actually, curious what exactly is happening. Isn't it how we learn that if you have 90 to 92% block, the probability of, an attack is high. And I'm actually, I don't know how to explain it to them. No, this could be, probably just, I can't tell it is a fluke, but what actually would be happening there?
There are a lot of alternative therapies. I think I mentioned earlier. There are a lot of alternative therapies. They may not have enough research to prove how they are acting, but there are a lot of things that we do not know actually. They have done wonders. Particularly, as I said earlier, some of the diseases that allopathy cannot treat at all has been treated by alternative therapies, alternative medicine, like Ayurveda, or homeopathy, or naturopathy, things like that. They may not have enough research to prove how they have actually, because particularly they're coming from India mostly or China. And so they may not be doing enough research to prove how they are actually doing this job. But they have done wonders. But unfortunately, when there are no clear research, no clear statistics around it, we cannot recommend it to anyone. You know what I mean?
Okay. Yes, right.
Yeah.
Right.
Okay, Meera, are you satisfied? Should I go for the next question?
Yeah. Thank you, ma'am. Thank you so much. Sir, I have to say this was a fantastic presentation.
Thank you.
Thank you, sir.
Okay, Meera. Then the next question is from Farisha. Farisha, are you there? The question is, you once said that you went for an ECG scan where you were able to understand that there is a problem with the reading.
Yes.
How will we come to know about it?
That is a very difficult question, unfortunately. If you can't read ECG, I could understand that only because I can read ECG, you know. So if you can't read ECG, maybe what you can do is, it's very easy to, at least, you know, it's very easy to learn how to do ECG. You know, to learn how to interpret ECG, it's not easy. It's very difficult to learn how to interpret ECG. You need to spend years of, a few days of your intense class to learn how to read ECG. If you're interested, I can teach you. But to learn how to do an ECG is very easy. At least where to, you know, the electrodes that we put on the patient's body, you know, you would have had an ECG for yourself. So you know where those electrodes are put on your body. So that is very easy to learn. If you can just Google it, in 5 minutes you can learn how to do an ECG. So if you know how exactly or where exactly the electrodes are to be placed, and if the technician or the nurse or the person who is actually doing an ECG for you, he will know whether they are putting those electrodes at the right place. And if they are not putting the electrodes at the right place, you can expect some kind of abnormalities in the ECG, which is not a real abnormality. So you can definitely tell this person, could you please put this ECG electrode at the right place? So that may be good learning.
Okay, that's great. And the next, is there Tushara Girish from Kannur Medical College? Are you there? Tushara.
Yes, ma'am.
I want to ask something to sir.
No, ma'am.
Okay. Then the next. Wait, I think. Oh no. Okay. More questions. Are the emotional trauma do really affect heart?
There are some studies done on that as well. Actually, if you have got already there's a cause for heart attack, then an emotional trauma actually can precipitate. It can actually bring on heart attack. And sometimes there are syndromes like broken heart syndrome or apical ballooning syndrome. Those kind of syndromes actually can, they have been found to be caused by emotional trauma as well.
Okay, how this is the last. Okay, you please go for Ms. Jovita.
Very informative, because in movies and all we are always seeing this. So from childhood onwards, I was very curious that whether this is having any effect or not. Okay, thank you.
You're welcome. Thank you.
So I think this is the end of all the questions. I hope in the chat box I could find whatever I found. I mean, I asked. Now I request if the participants have to ask any direct questions to sir. Would you like to interact with him with any questions? Okay. And now I request Ms. Ambali Elizabeth George, Assistant Professor of Department of Zoology, to propose vote of thanks.
Good afternoon, everybody, and Mr. Anu Peter, our resource person. And first of all, I thank everybody who participated in this program for this solid 2 hours, and from all over India and abroad, to this international webinar on Love Your Heart and Celebrate Life. And let me thank our college, our principal, Professor Saji Joseph, and our HOD, Dr. Annie Kurian, for giving this opportunity and being in contact with our amazing resource person. And thank you all for the support, and thank you for the staff of Nirmala College for giving the technical support for this program. And now I will come to I'm really grateful to extend the sincere gratitude of Nirmala College and Department of Zoology to Mr. Anil Peter, the faculty of the Department of Cardiology in the St. George Hospital, Sydney, Australia, for giving this amazing, wonderful class. And you were clarifying the questions for almost 1 hour. And that is a really huge thing. And thank you so much for this, for giving us this opportunity to host this program.
You're welcome, Amber.
And being there. Yeah, thank you, sir. And now I'll thank all the participants from all over India who asked these questions, and they clarified everything which they want. And we thank you all for your appreciation you have given. Thank you again. Thank you so much.
Thank you.
So that was the formal proposal of vote of thanks, and I also thank, along with Miss Ambali Elizabeth, I again thank you all, and I thank the resource person, and thank you for being with us for this much time, for 30 to 40 minutes, but it's almost 2 hours. And it's great that you did this much for us. Thank you so much, Anil.
Thank you, Annie. It was really great, the time that I spent with you guys. It's really interesting to talk to you all. People are really curious to know things, and they when they ask those questions, it also means that they are ready to act. They're ready to look after themselves. Look after their heart. It's really a privilege to talk to you, Annie, and all the people listening to me. Thanks.